Hi everyone, you should have just gone live on your webinar link if you have signed in early. Technically it is 2 o'clock, so we are going to get started. I do see the attendee list climbing as I speak, so I think folks are dialing in right now. This is Elizabeth Myers. I'm the Deputy Director of the Office of Policy here at ONC. I have several members of our team on the line today. I'm going to ask them to hold on introducing themselves until we get to the Q&A portion of our webinar today, and each of them will introduce themselves whenever they are called upon to answer one of the questions. I'm going to go through a little bit of logistics in just a moment, but first I did want to thank you all for joining us. Some of you are just dialing in as I see the numbers going up, so we are going to get started here in just a minute. Today's webinar is the ONC 21st Century Cures Act Notice of Proposed Rulemaking Overview and Q&A webinar, a nice long title to go with a meaty and robust rule. This is the 4th and final webinar in our webinar series. I did want to remind everyone that our prior 3 webinars, one that was a longer overview, one that was specifically on application programming interfaces, and one that was specifically on information blocking, have all been recorded, and those recordings, as well as the slide decks from those past presentations, are available on our website at www.healthit.gov/NPRM. I am going to point out a couple other things that are available on our website before we kick off our main presentation, but before I do so, I want to just remind everyone, I'm going to go to our disclaimer slide here for a second, that ONC must protect the rulemaking process and comply with the Administrative Procedure Act. This means that during the rulemaking process, ONC can only present on the information that is in the Notice of Proposed Rulemaking as it is contained in that NPRM. So we cannot interpret that information nor clarify or provide any further guidance on the intent behind the information in that rule. We cannot also address any public comment or suggestion or statement made by anyone attending the presentation today, or consider any such comment or suggestion as part of the rulemaking process. Again, that means that any comment or suggestion or use case identified today during our Q&A portion is not considered a public comment for the purposes of our rulemaking. If you do want to make a public comment, you do need to submit your comments through the formal process outlined in the Federal Register, and comments are being accepted through May 3rd. So I want to remind everyone on our website again, www.healthit.gov/NPRM, you can find a link to the Federal Register so that you can comment on the rule. We have also just posted templates that can be used to help support your submission of your comment and the organizing of your comment based on the content within the NPRM. So you can find that on healthit.gov/NPRM as well. You can find those decks and prior recordings from our previous webinars. And finally, you can find a series of information graphics that contain the information in the rule presented in a visual fashion, which some folks find helpful for understanding more contextually each of the proposals that are contained within the rule. So I see our attendance is starting to taper off here, so I am going to kick us off by handing it off to Kate Tipping, who is the director of the division, of the branch under our Regulatory Affairs Division in the Office of Policy at ONC. Kate?
Thanks, Beth. Like Beth said, I'm going to try to keep this shorter. We do have a longer, more in-depth version of an overview of the rule that was provided last month. So looking at the agenda slide, if you want to go to the agenda slide, we provided an agenda because there's a lot of content here I want to touch on. And as you'll see, the slides are pretty substantive. There's a lot of information we include on them. I will not go through all of it. And like I said, there is the recording from the prior webinar on our website. So the next few slides, I'm not going to spend much time on, but we'll provide a quick overview of the provisions in Title IV of the Cures Act that we intend to implement in the proposed rule. So going from pediatrics to the conditions of certification, maintenance of certification requirements, the interoperability definition, and the next slide, Looking at information blocking and the 7 exceptions, we also include a request for information for exchange with registries, which is in section 4005, and then 4006, patient access. We focus on patient access throughout the rule, and you'll see that from information blocking to the conditions and the criteria and all of the policies that we propose. Another goal, next slide, is to support the executive orders from the President about promoting healthcare choice and competition through the rule and support innovation that can happen through the APIs without special effort and allowing patients to access their information at no cost. In addition, we thought about activities that would reduce burdens. One of those being we're proposing to remove the 2014 edition from the Code of Federal Regulations. Now that the 2015 edition is in place, and in this rule we propose updates to further improve interoperability. The 2015 edition has more up-to-date standards, is referenced by other HHS programs. Therefore, we propose to remove 2014 edition to reduce the burden of having the 2 editions. So that's just an example there. So again, the purpose of the rule is to implement Title IV of the Cures Act and support innovation and competition, giving patients and healthcare providers safe and secure access to their information through new tools and allowing choice for patients and their care and treatment. And to also, like I mentioned, to reduce burden and advance interoperability. We propose to adopt the United States Code Core Data for Interoperability, or USCDI, which is an updated, more expansive standard, which includes a set of data classes to support nationwide interoperability. We also include API requirements and EHI export, providing patients more access to their health information, requiring certified health IT developers to support the switching of providers or where providers are moving from one developer to another, and support the ability of patients to pull down all of their electronic health information out of such systems. And again, mention promoting patient access, as you'll see as we go through the slides and throughout the rule. The first section of the rule that I want to get into is the deregulatory actions. So we propose 6 deregulatory actions. These are in response to executive orders from the President to reduce regulatory burden. But this is something that ONC has always tried to do. We've aimed to implement and administer the program in the least burdensome way, but to also achieve our policy goals. Briefly touch on the 6 deregulatory actions that we propose. The first is to remove randomized surveillance requirement, which we actually did through enforcement discretion, but now we are proposing to remove the regulatory requirement. This would allow the certification bodies to be more responsive to complaints. We had heard from stakeholders that requiring randomized surveillance was not as beneficial because it was taking up too much time with the providers when there was no problem reported. We will still allow it, but it will just not be, we will not be requiring the 2% threshold. The second item for the deregulatory actions is we're proposing to remove, as I mentioned, the 2014 edition. And we've done this in the past with the 2011 edition. As I mentioned before, the 2014 edition has older standards and older technology. Now that the 2015 edition is in place, that includes enhanced functionality that will improve interoperability. The third deregulatory action is more administrative, so we're proposing to remove the ONC-approved accreditor from the program. We determined that this could be duplicative in the oversight, so we're proposing to remove it, but will still be required to be accredited. And then the fourth one is the removal of certain 2015 edition certification criteria. We looked at the criteria and again tried to focus on reducing burden and improving interoperability. The criteria we're proposing to remove is more recording of information. It's been a part of the program since 2011, and no standards are associated with the criteria. The systems include these functionalities and we don't see them going anywhere, we just don't think it's necessary to include them as a requirement in the program anymore. And then the fifth one, we tried to look to see if there was any more duplication, and with the information blocking, some of the disclosure requirements we see that are no longer necessary, both because of the information blocking provisions and some of the conditions of certification requirements. And then the last deregulatory action, we've worked closely with FDA since the FDASIA report, creating a regulatory framework that reduced duplication but still promoted safety and innovation. And in FDA's software pre-certification pilot program, they look at the product, not the developer. So in the rule, we're seeing if we can, if the developer has gone through that process, could we somehow give them recognition so that there's not duplication. And then also we include a request for information on whether we should take a similar approach and maybe for certain criteria that are interoperability based. But if we do that, anything that's in this space, it would be in a future rulemaking. Okay, and then the next one, updates to the 2015 edition certification criteria. This next slide here, includes what we call the certification wheel. It's on our website here. We provide the link for it. It takes what is in the regulation and talks about the categories of the criteria and functionalities we're hoping providers adopt and users are using. So you can check that out. Again, that will be updated after the final rule is in place. And then for the proposed changes to the 2015 edition criteria, this first red box here, the removed criteria, I mentioned that just a few minutes ago. But if you look at the updated criteria, that's where we're removing certain criteria and updating it with newer criteria. So for e-prescribing, we're proposing to update the e-prescribing standard to align with other departmental requirements. So to align with the Part D e-prescribing standard. For data export, we're updating for the electronic health information export. The new proposal would require health IT developers to provide the capability to electronically export all EHI that they produce and electronically manage. And that would apply to 2 use cases. You know, we've heard it's hard to switch systems, so we're trying to address that and then also give patients access to their data. The data segmentation for privacy criteria, we're replacing that criteria. Currently, the data is tagged at the document level, and in the new proposed criteria, we're trying to have a more granular level of tagging. So for instance, in the proposed criteria, it would include data element level tagging. Also, I want to mention, now that we're talking about data segmentation for privacy, one of the new criteria, the consent management for API, we're proposing to support data segmentation and consent management through an API in accordance with consent to share implementation guide. And then the fourth one, the application programming interfaces, we propose to adopt a new API criterion, which would require the use of FHIR standards and several implementation specifications. And we'll get into more detail on the API, and there was another webinar that Beth had mentioned, so you can check out the recording for that. And then looking at the revised criteria, the clinical quality measures, we propose to remove the HL7 quality reporting document architecture and replace it with the CMS QRDA implementation guide. We do welcome comments on that proposal. In addition, under the revised criteria, we're updating any CCDA-based criteria to align with the US CDI companion guide, as well as updates to any certification criteria that reference any minimum standards code sets that are updated. And then under the new criteria, the privacy and security transparency attestation criterion So we're basically asking the developers, do you have this functionality, yes or no? So for the first one, do you encrypt authentication credentials, essentially the passwords, yes or no? And then do you use multi-factor authentication, and what do you use it for? So that's just a quick snapshot of the changes to the 2015 edition. As I mentioned, the other webinars has gone into more detail, so you can look to that and to the rule. Okay, next is the conditions and maintenance of certification. So this is a new requirement Congress put forward in the Cures Act. It's focused not so much on the health IT, but to the health IT developers' behavior. And all 7 of these conditions here are in statute, except as you can see here, number 7, we're not proposing to implement in this rulemaking, the EHR reporting criteria submission. We're waiting for the criteria established for the EHR reporting program, and this is on a separate track, so that would be established in a future rulemaking. So briefly touch on each of the conditions. So for information blocking, basically a health IT developer must not take any action that constitutes information blocking. For the assurances, a health IT developer must provide assurances to the secretary that they will not take any action that constitutes information blocking or any other action that may inhibit the appropriate exchange, access, and use of electronic health information. In the assurances section, we include a request for comment whether the developer should be required to participate in the Trusted Exchange Framework and Common Agreement. And then we also include some requirements that the health IT developer must ensure that the certified health IT conforms to the full scope of the applicable certification criteria, that if they produce and electronically manage the electronic health information, they must certify to the 2015 edition Electronic Health Information Export Certification Criterion, and that they have to retain their records and information necessary to demonstrate ongoing compliance. In the communications condition of certification, require that the health IT developer doesn't prohibit or restrict communication. And then we have some exceptions, limited exceptions. Certain prohibitions and restrictions on communications by the developer could be permissible when it would infringe upon the intellectual property rights. So for instance, screenshots. So exchanging the screenshots is fair use if of the intellectual property rights, as long as certain conditions are met. So they can't change the screenshot in any way. It cannot include any PHI and not expose any third parties' intellectual property rights. And the developer has the responsibility to not release the third party information. And then for any of these in the communications condition, the developer must notify the customers within 6 months of the effective date that any communication or contract that violates the communications condition. So they have 6 months to get it out of the contract. So the gag clauses, we've heard that the gag clauses shouldn't be in contracts. So we're trying to, through the program, trying to implement and enforce that. The next condition, the application programming interfaces. This one, I'm not going to go into too much detail. Basically, focus on the transparency, the fees, pro-competitiveness. I'm going to just leave it at that for that one because of the other webinars and information that we've provided, and I want to get through this. So for the next one, real-world testing, we tried to balance the burden, but also advance interoperability here. So requiring the health IT developers have successfully tested the real-world use of the technology for interoperability in the type of setting which the technology would be marketed. So this applies to health IT developers with health IT modules certified to certain certification criteria focused on interoperability. And the developers must submit real-world testing plans and the real-world testing results for the certified health IT products. And those plans and results will be made publicly available. Also, in addition, on the real-world testing, we've included the standards version advancement process, which permits health IT developers to voluntarily use newer versions of adopted standards. We did provide a fact sheet on our website to kind of walk you through the standards version advancement process. And then the next item, the next condition, the attestations. The health IT developer must provide an attestation to compliance with all of the conditions of certification except for the EHR reporting criteria submission. And then moving on. So for the enforcement of the conditions and maintenance of certification requirements, how are we going to enforce? Well, using a process we already have in place through the regulatory framework, through the enhanced oversight and accountability rule, which allowed ONC for direct review for health IT. We're going to use that for the conditions of certification enforcement and the compliance. ONC is best situated to do the enforcement for the conditions, and we may also coordinate with the Office of Inspector General, particularly with information blocking claims, and we can rely on the OIG's fact-finding in order to do some of the enforcement. And then the next slide, this is basically just the approach, the steps. But if you look at step 6, if the developer gets through the whole process and doesn't want to address, they could be the issue. They could be banned from the program. So Congress thought about this behavior and actually put it in statute. So if violated, it could result in a ban. Okay, and the next one I'm just going to briefly touch on. This is really geared toward the developers. These are technical changes. If you go to the next slide, you can see they're laid out. Mainly, this is for the certification bodies and testing labs on what they are required to do now. And then, as I mentioned, there were some flexibilities. For instance, the role of the ONCAA would be eliminated, but permitting the ONC-ACBs to select their accreditation body of their choice. So we're trying to provide some flexibility, and then also, as you see, we no longer require certain disclosure requirements or transparency attestations. And then there's obviously more detail on that in the rule. Okay, next is information blocking. I'm going to try to move through this pretty quickly. Again, there was an entire webinar on this on March 19th. Also, I wanted to note that there is some more information on ONC's website with regard to the HITAC meetings. There was a presentation last Friday, and the recording and the slides are posted on that gives you a more deep dive into the information blocking provisions. So first, Section 4004 authorizes the Secretary to identify reasonable and necessary activities that do not constitute information blocking. Congress also laid out like who the actors are. So if you look here on the slide, healthcare providers, health IT developers, of certified health IT, health information exchanges, and health information networks. There was also included a definition for the actors, one for the providers, and then for the other 3 actors, which is discussed in the rule. So in addition, there's different types of penalties depending on who the actor is. So for healthcare providers, they could be subject to appropriate disincentives as determined by the Secretary, and we request comment on that. And then for the other 3, there could be penalties up to $1 million in fines per violation, and that would be determined by the Office of the Inspector General. The Office of the Inspector General is the lead enforcer for this section, and will consider the actor's activity and whether it falls into the reasonable necessary activities. ONC has laid out 7 reasonable and necessary activities. So to fall into these exceptions, you really need to look at all of the subcomponents. And an actor could claim one or more of these exceptions. Okay, next slide. So what makes an individual or an entity an information blocker? First, I'm going to go through what information blocking is as defined. So a practice by a healthcare provider, health IT developer, health information exchange, or health information network that is likely to interfere with, prevent, or materially discourage access, exchange, or use of electronic health information. And these are the elements laid out here of information blocking. So is the actor regulated by the information blocking provision? Does it involve electronic health information? Practice likely to interfere with, prevent, or materially discourage access, exchange, or use of EHI? The requisite knowledge of the actor, whether it's required or not required by law, and not covered by an exception. So the presumption is that the information is moving for the benefit of the patient or the provider, and where it's not moving has to be either because of one of these 7 exceptions, and this is what the Office of Inspector General would look at to determine whether the action is likely to interfere with, prevent, or materially discourage access, exchange, or use of the EHI. Okay, next slide. So the electronic health information, this is the definition. So if the electronic health information does not move, that's when information blocking comes into play. So we define health information, electronic health information is transmitted or maintained in electronic media, identifies the individual or with respect to which there is reasonable basis to believe the information can be used to identify the individual, or relates to past, present, or future health or condition of an individual, the provision of healthcare to an individual, or the past, present, or future payment for the provision of healthcare to an individual. Again, it's not limited to information that's created or received by a healthcare provider. And in addition, de-identified information would not fit under this definition. So those are the components we think of for purposes of EHI, but we do welcome comment on this definition. Next slide. So for price information, we included a request for information on this category. We want to learn a little bit more about what are the parameters or implications that might apply when including the price information within the scope of the definition of electronic health information. And then in addition, the department has noted that there is an impact on the provision of healthcare across the care continuum when price information is not moving. And there's concerns about access to such information. So the department seeks comment on a number of issues related to price transparency, and you might want to check the rule for the additional details, but we do encourage comments on these points. Okay, next is the exceptions that we're proposing. So again, the movement of the information is the primary goal, but there could be situations where moving the information could result in harm. So for the first exception, or where there are security or privacy concerns. So we want to make sure that all of these exceptions are available for some of these realities and are considered. So the goal is not to allow for the information to be prohibited by using the exceptions as an excuse. We want to make sure it's reasonable and non-discriminatory. So for the second exception, the promoting the privacy of electronic health information, there's 4 discrete sub-exceptions that address the scenarios that recognize existing privacy laws and privacy practices. So for instance, you need to take into consideration state law or HIPAA, respect individual privacy preferences. Okay, next slide. Promoting the security of electronic health information. The actor may implement measures to promote the security of the EHI, must be directly related to safeguarding the confidentiality, integrity, and availability of the EHI, and it must be tailored to specific security risks and implement it in a consistent and non-discriminatory manner. And then the fourth one, recovering costs reasonably incurred, really lays out where the cost can apply to the movement of the information, not to support a situation where the cost can be used as a means to information blocking, but rather cost applied to and is objective and verifiable criteria uniformly applied to all similarly situated persons and requests. Okay, and then the fifth exception, responding to requests that are infeasible. The actor may decline to provide access, exchange, or use of EHI in a manner that is infeasible. Complying with the request must impose a substantial burden on the actor that is unreasonable under the circumstances, and it must be the actor must timely respond to these infeasibility requests. And then the sixth exception on licensing of interoperability elements on reasonable and non-discriminatory terms. The actor that controls the technologies or other interoperability elements that are necessary to enable access to EHI will not be information blocking so long as it licenses such elements on reasonable and non-discriminatory terms. And then next slide, the seventh exception, maintaining and improving health IT performance. So we're aware that sometimes systems need to be taken down to address issues or maintenance, and in these situations, we wanted to provide for an exception. But in circumstances where the health IT is supplied to an individual or entity, the individual or entity or customer must agree to the unavailability of the health IT in a consistent and non-discriminatory manner. Okay, the next part, the complaint process. So the statute requires the national coordinator to implement a standard way for the public to submit an information blocking claim, and we intend to do so by building on existing mechanisms, including the complaint process that ONC already has in place. We do request comment on this approach. We also request comment on whether additional exceptions. So we just went through 7 exceptions that we are proposing, but we request comment on whether we should, in a future rulemaking, consider an exception for practices that are necessary to comply with the common agreement, and then also whether there are other exceptions that we should consider. And then with regard to disincentives for healthcare providers, we request information on the disincentives or modifying the disincentives already in place under HHS programs, and regulations would provide for more effective deterrence. So I'm just going to, in the interest of time, quickly touch on the PED section. So we look at pediatric care. We noted 10 recommendations, as well as identified certification criteria, either the new or current, that support pediatric care and practice settings. Those who operate in this area would be able to consider and work with developers to support the pediatric patients. We're looking for comments on this. We also did do stakeholder engagement, including working with ARC and CMS on things such as the children's EHR format. And then on the next slide, you can just see the 10 recommendations and the criteria that we looked at. And then finally, I just want to note some additional requests for information. Some I touched on. For instance, if you go to the next slide, the ONC development of a similar independent program processes to that of the FDA software pre-certification program. We also included a request for information with regard to opioid use disorder. So we request public comment on how our existing ONC certification program requirements and proposals in this rulemaking may support opioid use disorder prevention and treatment, or if there are additional areas that we should focus on. And again, I mentioned in the condition section, the trusted exchange framework, whether certain health IT developers should be required to participate in TEFCA as a means of providing assurances to their customers. And then two separate sections that we have, requests for information in the rule. We have the exchange with registries, where we're requesting comment on how a standards-based API might support improved information exchange between a healthcare provider and a registry. And then patient matching, where we're requesting information on additional opportunities that may exist in the patient matching space, and ways that ONC can either lead or contribute to the coordination of these efforts. And then I also note, these are the implementation milestones that we're aiming towards as part of our rulemaking development. So if you just want to take a look at those, and then again at the timeline set forth in the preamble and the regulatory text. But in closing, we spent a lot of time listening to stakeholders, and we tried to, do our best to address those in this rule, what we think would be helpful. But, ultimately, we did what Congress had asked us to do. Just a reminder before we get into the Q&A that comment period closes on May 3rd. This was our final public webinar, and we do, if you check out our website, now up is the public comment template, as well as some resources. So I will turn it over to Beth, if you want to start the Q&A. Okay, so Beth, are you there?
Apologize, all. We were muted twice. Can you hear me now?
Yes.
Okay, perfect. Sorry about that. So I will ask that everyone who is interested in submitting a question, please use the Q&A feature on the Zoom webinar. You will see up in your taskbar, whether it's at the bottom or up at the top, a little bar that says Q&A. You can click on that and submit a question. It is much easier for us to use that feature to navigate your questions than to use the chat. So please do use that feature to submit a question. I'm going to pull up the first question for our participants. I'm actually going to ask Steve Posnack to answer this particular question. We have a question that says, I thought I just heard a statement that developers and implementers will be allowed to use newer versions of standards. Did I hear that correctly? Can you point to that in the NPRM?
All right. Hey, thanks, Beth. And for everyone that missed the first time that Beth gave you the Q&A discussion, she did the exact same thing, so you didn't miss anything. So as part of the real-world testing condition of certification, we have a proposal that is associated with the maintenance of certification requirement, which is another part of the Cures Act's requirement. There are both conditions and maintenance of certification requirements. For those certification criteria for which there are interoperability standards associated and attributed as part of the real-world testing condition of certification, we've proposed a new process as part of our regulatory structure called the Standards Version Advancement Process. And what that would do would allow, after we've adopted a standard implementation specification in a final rule, that would allow the national coordinator to go through a public process to identify new versions of adopted standards, and as they may be applicable or available to reference for voluntary use by industry to move ahead and keep pace. And if there are health IT developers out there that are on the leading edge, they would be able to move forward on a voluntary basis, provided that the national coordinator has approved that new version for use in the certification program. And that's kind of a nutshell of that new process. So if you search for standards version advancement process, that will take you to our proposal.
Thank you, Steve. I'm going to go ahead and take one of these questions myself. There's a question that asks guidance for commenting on the CMS rule versus the ONC rule and/or both. To make it very clear what the requirements are in the Federal Register, we can only accept comments on our own rule under our own authority for consideration in our rulemaking, and the same thing applies for CMS. So while we obviously talk to each other and have coordination in making sure that the rules were aligned, if you want to comment and want your comment to be considered for either one or both rules, you do need to specifically submit that comment through the Federal Register on the applicable rule. So if you are sending the same comment for both rules, you actually need to send the same comment on both rules. So that is that one. So I have a question that says, in the definition of EHI, what else is there besides information being created and information received? Mike, do you want to talk a little bit about the definition of EHI?
Hold on. Hi, can you hear me now?
Yes, we can.
All right, same issue, double muted.
Right. Mute with both sorry about that.
Yeah. Hi again. This is Mike Lipinski. I'm the Director of the Regulatory Affairs Division within the Office of Policy here at ONC. So the definition of the EHI is very broad. We give in the rule some examples of the information that includes. And it's really about the information that is held by a covered actor, right? So, you know, we don't put any specification on who has created it or who it was sent by, for example. It's what information one of these actors who are covered by the information blocking provision have, and it has to be in an electronic format. And we talk in the rule, and as you heard Kate talk about, you know, what does that include? And so it's a very broad definition again. It is based off of the definition of essentially identifiable health information under HIPAA. It starts first with the definition of health information, which is in the Public Health Service Act and via cross-reference to the Social Security Act, same definition as you'll also find for HIPAA purposes. But some examples, you know, is billing for healthcare services can be part of EHI. Individuals' health insurance eligibility and benefits. You heard Kate talk about price information, which is really part of payment information, because the definition includes, again, you know, future payment. So that's kind of like, you know, how broad it is. We talk in the rule about focusing on, for purposes of info blocking, observational health information, which is more that clinical health information in terms of, you know, caring and treating for a patient. So hopefully that helps a bit. And I did want to, I think maybe it's a good time to mention, because I saw some of the questions about this. The webinar we did just on information blocking and the slide deck that went with that should be posted shortly. It's just going through a process right now to be compliant with Section 508 of, I think it's the Rehabilitation Act, so to make sure all folks can use it. So I'm hoping that will be in the next couple days, and it'll be posted on our website. And there's still the recording. I believe that is already there if you wanted to listen to that presentation again, where we go in a little more detail about EHI. Back to you, Beth.
Thanks, Mike. I'm actually going to send it back to you with the next question.
Sure.
Sure. In light of the recent enforcement action against Greenway's alleged using fraud, does ONC have concerns that lack of surveillance poses a risk to patient safety?
So let me start by maybe tackling the underlying assumption there that there's a lack of surveillance. So what we're proposing this rule is really just codifying an enforcement approach that we took a couple years ago now. I think it was in the fall of 2017, which is just to say that we weren't enforcing a provision that required 2% of products be randomly surveilled. Okay, so randomly surveillance simply means you just show up at a install, that would be the certification body, at an install site, and say we're going to look at the product, see how it works right here. We got some feedback about that. Well, you know, there is value to it, but we received some feedback that said, look, you're just coming in, it's becoming burdensome to us providers in those situations, and we have no complaints with the product, okay? So we took away, that's what we took away, just a requirement to do it. We didn't take away a certification body's, or were we proposing to take away a certification body ability to do that randomized surveillance. And what I want to drive home most importantly, and to whether it be Greenway or eClinicalWorks settlement in the past, is those were actually both, as you can from the settlements, that were a result of information provided to us, so or to the federal government, that is. So complaint driven, you know, I don't know how to say it other than, you know, it wasn't necessarily a complaint, but information provided. So it wasn't a result of randomized surveillance. So, and that's what we found. I've always found that most of when there are non-compliance identified with certified health IT, is as a result of someone coming forward with that information, not through a random inspection of the product. So we feel confident that providers and users of certified health IT should remain confident in the products that are certified, even with this provision being taken away. And not to go on forever, but lastly, in this proposed rule, there'll be additional attestations on behalf of the developers through the conditions of certification, where they will attest, and that attestation is subject to OIG authority for false attestations. If they will have to test that their product complies with all parts of a criteria and all related requirements in the program, and that when it's in the field, that it will still be able to do that. And further, they'll have to do real-world testing. So we feel like there's quite a strong framework within the program to give users and providers confidence in the health IT. Sorry if that was pretty long-winded, but hopefully that answers why we feel okay with our proposal here.
Thank you, Mike. I have another one for Steve Posnack and the OTEC team. Has the ONC received comments about potential privacy issues with the use of a third-party app that shares information with another entity, for example, Facebook? We understand that HIPAA does not apply to third-party apps, excepting specific circumstances.
Yeah, great question, and I appreciate this being raised. And it's really, the answer is we've certainly had lots of discussion with stakeholders about the concerns with which data flows. Obviously, there are a number of different regulatory layers to keep in mind. There's our rules, which are about enabling the technical capacity for data to be exchanged. You know, in some cases via APIs, in other cases for different certification criteria that we have, like you know, transmitting data to public health, or for a transition to care, electronic prescribing, and the like. When it comes to the particular situations of you know, data being disclosed to a third party, and you have to keep in mind as the question so framed, the HIPAA privacy rule context, as all of us as patients having the access right under HIPAA to request that a healthcare provider send our health information to a designated third party of our choice, and separately, you know, as that information exchange occurs, once the data is within that third party to whom I've asked my data to be sent, there is a gap in the larger legal and regulatory structure today, and it is incumbent on all of us to make sure that the apps that we choose to hold our data or be the steward for our data, you know, we read through the various terms and conditions, but for the purposes of getting that data to the third party, that is a direction that we have to initiate and make occur, so to speak, for lack of better words. We would encourage everyone to make comment on your concerns related to these issues. We certainly, as Beth mentioned, our collaborative relationship with CMS. We work hand in glove with our colleagues at the Office for Civil Rights at HHS, and equally with other federal partners that may have a role in this space too.
Thank you, Steve. I'm going to ask Mark Nee if your phone is presently working. I'm going to ask a question for you. There's actually several questions that follow along the same line, so I'm going to do the best I can to sort of summarize and aggregate on the fly here. There are several questions asking about essentially where the actors' definitions come from in information blocking. So asking questions like, is a specific type of HIN covered? Is a payer, specifically, is one of the asks, and a public health registry are both the two specific asks that have been put into some questions. Can you just outline a little bit about what the, especially the Health Information Exchange and Health Information Network definitions currently do and do not include in terms of especially payers and or public health agencies?
Yeah, sure, Beth. Hi, everyone. This is Mark Nee from the Office of Policy. Can you hear me okay?
Yes, we can hear you. Thank you, Mark.
Okay, great. Okay, so in Cures Section 4004, Congress identified 4 categories of actors that would be covered by the information blocking provision. They talk about healthcare providers, health IT developers, health information exchanges, and health information networks. And as Kate talked about in her presentation, in order to be covered as, or to be looked at as an information blocker under the rule, you'd have to fall under one of those categories of actors. And we define those categories of actors within the proposed rule. So we often do not call out a wide range of specific entities that would be covered. We provide some examples. For instance, we do talk about registries as a type of HIE in the rule, but we don't talk specifically about other entities, and you would need to look at the specific definitions provided within the regulation to determine whether those individuals or entities fall under the categories of actors we define that were provided to us through Congress's language in the Cures Act.
Thank you, Mark. I actually have another set of sort of grouped questions that I will pass to Mike or Kate. Up to you which one of you wants to hit this. The next set of questions that are sort of an aggregate on the fly here is 2 things. Whose law applies to what? So a little bit about the applicability of the rule and the Cures Act, both in relation to potential other state legislation, HIPAA, things like 42 CFR Part 2 have come up. And then there are also several questions about whether this applies only to Medicare and Medicaid participants or more broadly. So maybe giving a little bit about the other 2 actors that are noted in information blocking, are health IT developers and certified health IT, and then also what we mean by providers and who is covered by that. And then also try and sweep by the applicability as compared to, for example, state laws.
Hi, this is Michael Lipinski again. I'll take that one. So I'll start, and I assume that's about information blocking. What I guess they're asking if there's some type of preemption or what conflict.
Thank you.
So with information blocking, Congress was pretty clear. I don't know if we could go back maybe on the slide deck just so folks can see that, the definition at least of information blocking. And if not, that's okay. Primarily what Congress said is it is, any practice that likely interferes with the access, exchange, or use of information is, and yeah, so this is a really good slide in terms of kind of showing you how the like kind of from a legal sense of prima facie case of information blocking. So it's any practice that likely interferes, and the only way that it's not information blocking is if all these elements are not met. So one of them, as Congress laid out, is not required by law. So we don't go through every potential law in the rule that could say that certain information doesn't get shared in certain circumstances. Because there's state law, the grants even, our interpretation is when they say that required by law, that would be both federal and state law. So, because there are certain privacy laws at the state level that might say don't share certain information in certain situations. Now, with any claim of information blocking, it's going to be fact specific. So, you know, you're going to look and see whether or not it was covered by an exception that we're proposing once those are finalized for why they didn't share it, or whether a law said don't share such and such information in such and such situation, and whether that applies to the claim that that was info blocking or not. So it's going to be fact specific, but it does allow for that. If there's a law that says not to share it in a certain instance, that it wouldn't necessarily be information blocking. As far as HIPAA goes, though, because that's the one we focused on when we're looking at the privacy piece. HIPAA, if I was to characterize it, we're definitely aligned with HIPAA, but to say how we differ is that HIPAA is more of a discretionary in terms of disclosing the information, so certain conditions have to be met before that information can be disclosed. The way info blocking approaches that is there should be a policy in place by a healthcare provider or a covered actor on how they are going to meet those conditions so that information can be shared. So the obvious one that is always, is there consent or authorization by a patient? So simply receiving a request that doesn't have that, do you have a policy in place on how that patient was giving the meaningful opportunity to have consented or authorized that disclosure of information? And our provisions go to the point of saying, like, there shouldn't be any type of trying to discourage the patient not to. So hopefully that helps in terms of from how other laws apply. I think it's what was the other particular question again, Beth?
The provider types. There are several questions asking who in terms of providers that it applies.
Sure. So when that presentation gets posted that we gave on 4/19, it'll start to lay out some of, in one slide, I think it's the various providers that are covered. What we're also going to do, because we gave a presentation to our task force on our health HITAC, our advisory committee, federal advisory committee, where we went even more in detail about all the cross-references that the statute has to certain providers. But just to give you a sense, that's going to be a pharmacy. A practitioner actually includes like a clinical psychologist, a clinical social worker. When you get into the definition of hospital, it includes a state or locally run hospital. When we talk in the rule about HIEs, we talk about state HIEs, and my colleague Mark talked about registries in our proposed definition. But we'll at least get you, so those are already in the rule, how we define like an HIE for comment. As far as healthcare providers go, we're hoping to get up a table that will provide you, I guess, help you ferret out what's in that actual definition in the statute, and we're pointing to as the definition of healthcare provider for this rulemaking. Okay, I think that covers that. Maybe back to you, Beth, for further questions.
Yeah, so we only have about 2 minutes left. There is, I'm trying to pick out the things that there are multiple questions on, folks. So please forgive us that there's going to be several that have not been answered. We have about 1 minute to try and answer one more that has been asked by multiple people. Mike, it's back to you one more time. As quickly as you possibly can, explain a little bit about the specific criteria that are being removed. I think problem list and medication list are mentioned in several questions as being removed, to clarify what that actually means, and that the standards for the data capture is not actually going away.
Right, and I really encourage you to look at that section of the rule. It's the deregulatory section. It's I think that's like maybe the preamble, and we discuss, because in some instances each criterion has a specific reason why we're proposing to remove it. But as my colleague Beth mentioned, most of these functionalities that we're proposing to remove are just recording of the data. And what has been since we first proposed these functionalities to be in health IT, they've only been about recording the data. Show me that you can record the data in your system, not in even a particular format. So you just had to show that. And a lot of it was because it associated with a, at the time, a objective and measure under the EHR incentive program. A lot of those recording data measures have gone away. So what you should be reassured with is that when we look at a health IT system, we're still ensuring that through that USCDI that it can format the data in the particular, data category, data element, use case, what have you, in the right format. So for example, I'll take medications or medication allergies. Previously, we just required, or do currently require as part of the 2015 edition, that data can be recorded, but not in a particular format. But when you get to the USCDI, which currently is still called a common clinical data set, a system has to be able to make that, depending on what functionality or use case we're talking about. So they say through the API, would have to make it available using the RX standard. So you should know that from an interoperability perspective, we are still continuing to support and promote that for this data. But for various reasons, some I've already mentioned, like not part of the Promoting Interoperabilities program, doesn't really support interoperability. We think the functionality is ubiquitous in terms of it's been in certified products since 2011. So you're talking 8+ years. We don't think developers are going to remove the ability to record medications because it's not part of certification anymore, really, from a bottom line perspective. And that we are still supporting the interoperability by making sure that data is available either for exchange, through the API, for download through VDT, in a standardized format. So hopefully that covers that.
Yes, thank you, Mike. So we are 2 minutes over. I'm going to go ahead and wrap us up. I wanted to highlight 2 quick things for everyone in part of our closing. First off, thank you all so much for attending. We very much appreciate it. We appreciate the good questions. There are quite a few questions that remain unanswered. I do apologize for that. But also some of those questions include some very specific use cases that we unfortunately would have had to say we can't answer that in response to them. I'm just going to remind you of that disclaimer that we talked about at the beginning with getting into deep interpretation. We really can't speak to things on a level of interpretation beyond what is written in the NPRM. So my suggestion is when you have those specific use cases that you're wondering how they interplay, how the cost would apply, that seems to be 2 of the big things. There's also a lot of discussion about would this particular entity serving in a particular role be an actor under information blocking. So for each of those things, please do take another look at the rule and also submit them as comment. Your examples and your use case examples are very helpful to us as comments to consider to understand the implications of the policies as we consider that for the final rule. The other thing I want to point out, because we did get a couple questions that were specific about potential cases of information blocking, if you suspect that there might be an information blocking scenario that you're faced with or that one of your customers is faced with, please don't wait for the final rule. Go ahead and submit on our feedback form and we can take a look at it and connect with the folks at OIG that are beginning to take a look at things and try and understand what the lay of the land is. So please don't wait for the final rule for those things if you have specific questions on that. Thank you again for attending. Please remember to submit your comments through the formal comment process outlined in the Federal Register. Again, if you are submitting for or if you want your comment considered for the CMS rule, you must do that for the CMS rule itself, for ONC rule, for the ONC rule itself. If you want it considered for both, you must submit on both. Comments for the rule are accepted through May 3rd. This webinar has been recorded and will be posted along with the slide deck on healthit.gov. People were asking about the availability of webinar number 3 on information blocking. We have been told that that will be up imminently, so keep an eye on that. You can also sign up for our listserv, which will let you know when those things arrive. Again, that website is healthit.gov/NPRM. Thank you all for coming.